welcome, and we've got three very, very interesting presentations, which are very detailed and very full. So just to make sure that everybody knows that this is being recorded, so you can look at it afterwards. The presentations will be posted immediately after the webinar, and a full report and the Q&A will be posted a little bit later when we've had a chance to put that together. So this is welcome from myself, Dean Ledbeater. I'm Chair of Health Stats User Group, and also from the RSS Official Statistics. And thanks to the RSS for hosting this for us. The presentations and the material will be posted in two places, well, actually in three places. They're posted on Stats User Network under the Health and Care Group, if you're familiar with that. They're also posted within Future NHS, the Analyst X community that we have there. If you're access to that. If you want to get access to that, email us and we can set you up with access. And then also on the RSS website. So you've got several options for looking at the material afterwards. We ask you for questions to put them in the chat, and we will run through all the speakers first, and then we will have a Q&A at the end, because quite often questions are relevant for more than one speaker. So we don't take queries between the speakers. So if you can do the next one, please, Catherine. Thank you very much. So our first speaker is Catherine, who's also acting as moving the slides through, which is very good. So we have the three speakers, Catherine, who's the Public Sector Productivity Lead at ONS, and then Paul talking from NHS England and the work that they're doing on productivity. And then slightly different, but complementary, Amar Shah from University of Edinburgh will be talking about some of the work that he's done on productivity and the impact of the pandemic and moving forward from that. So slightly different views on things, so that will give us a full range of interest, I think. And as I say, we'll have to run through some of these fact size quite quickly, but they will all be available afterwards. So right now, Catherine, it's over to you as first speaker.
Thank you. Thank you for inviting me to speak today to talk to you about how we measure healthcare productivity at ONS. What I'm going to cover today also covers the recent public service productivity review we did, which was a 2-year review. But given the time, I will be brief on all the aspects that I'm talking about today. And just a little bit about me. So I'm Assistant Deputy Director for Wellbeing, Innovation and Productivity. And as Deanna said at the start, I lead on public service productivity. What we're going to cover today is how we measure public service productivity for the UK, with a specific focus obviously today on healthcare productivity estimates and how those are constructed. I'll briefly mention the public service productivity review, which was a 2-year review, what the key deliverables were from that, and then two things to leave you with. So one improvement that we introduced in March this year, which was an equivalisation of weights approach, and then leave you with the big question, which is around how we measure preventative services. So let me move on. So here we go. So what is public service productivity? I thought this was a good place to start because productivity means different things to different people, and sometimes in the public service context it gets lumped in with efficiency, which is often seen as doing more for less or the same for less, whereas often productivity is about pushing the boundary and doing more for the same or even more with more resources. Looking at this diagram, the part that I'm particularly interested in is starting with inputs. And the inputs in our case is things like in the healthcare setting would be number of doctors, number of nurses, number of pens, various things, and the capital consumed. So the way I'm talking there, you'll see that it's all in a volume context. So what we've done is removed that sort of effect of budgets and price movements in that sort of thing. So it's all in volume terms. That means that start piece, that public money, there is still a productivity piece there to be done on terms of how efficient people are at negotiating procurement contracts, for example, or allocating budgets that Treasury would do. But my starting point for the measures is that inputs piece. Then traditionally, productivity is a simple ratio of outputs divided by inputs. So what do you get out for what do you put in? And outputs here is thinking about, if we were thinking in a hospital setting, it might be the number of knee operations, number of hip operations, the number of GP appointments, the number of dental appointments, those sorts of things. But what you key missing there is the fact that you haven't got any sense of the quality of those things that have been provided. If this was a private company, we would have a market price. And if someone always provided a bad level of service or what they were getting didn't deliver, the price of that would be much cheaper than the sort of the gold standard. So what we have to do is think about how we would move to outcomes and thinking about the quality of that as a replacement for price. So there's two different aspects of productivity there then. There's the doing things right, so technical efficiency, so how well you produce these things based on the inputs that you've put in. But also there's a broader question about, are you doing the right thing? So is the ultimate aim of better health outcomes for patients being satisfied? So that's linked to allocative efficiency. So that's what we work on. So if we move to the next slide, if someone has got control, brilliant. Thank you. So this is the ratio of productivity. So it's the quantity of output and then the quality of that output, which we call quality adjusted output, divided by the inputs, of which we have three, all encompassing, which is labour, capital consumed. So that's the fact that you're in a building, the hospital is generating capital for the services you've provided, and intermediate consumption. So that's spending on things, so goods and services, and that's the inputs. So if we move on. So it sounds quite straightforward, but actually it's really quite challenging. So this is like the history of how it's been evolved. Healthcare has, the measures of healthcare productivity have been around for a while, but originally we didn't have a measure. So we started out with what we call an inputs equals outputs approach. So effectively say what you put in is what you get out. And in some service areas, for example, defence, we still have that approach. But what that means is that you can't measure productivity then, because you haven't got that differential between your outputs and your inputs. The big turning point was the Atkinson review in 2005, where Sir Tony Atkinson introduced this concept of quality adjustment as a proxy for price. And following that, there was a big work within ONS to develop measures, and the focus was mainly in health and education. In more recent years, we've expanded that. So following the Bean review, we expanded that to cover adult social care, public order and safety. And then right at the end, which I'll talk more about in a minute, is the Public Service Productivity Review, which gave us an opportunity to bring this all up to date and take into account any methods that needed review because of the COVID pandemic. So next slide, please. Fabulous, that's perfect. So I think everyone will probably understand that healthcare is a very important part of our public services. It makes up about 40%. And we, as I mentioned before, the gold standard approach to doing this would be a quality adjusted measure. We have quality adjusted output measures for around 70% of the things that make up healthcare, and it's quite granular. And quantity adjustment for 20%, and then there's still an element, particularly around the sort of independent providers. So where perhaps NHS will pay for operations to happen in a private setting, we still have inputs equals output measures for that. So we still have some areas that need improving. But you can see how that compares with some of the other service areas in the chart on the right. So let's move on. Lovely. And this is to set in context our latest statistics. So we produce different measures within ONS for healthcare productivity. So we have annual statistics which are very detailed, but they have a 2-year lag. So our last publication covered 2022, and our next publication in March will go up to 2023. We also provided England only financial year, the data set that sits alongside that, because of the interest in England measures. But usually our measures are whole UK. But users are obviously very interested in what's happening now or what's happened in the recent past. So we also have a quarterly publication, which is Official Statistics in Development, which uses nowcasting approach to come up with an annualized measure for the last 2 years, so for 23 and 24, and a quarterly tail, which is based on output measures only, so it holds quality constant. So we don't have those detailed quality measures that we would do on an annual basis. As you can see from the chart, we had a steady increase in productivity in health, around 0.8% per year, up to the COVID pandemic, which caused a big drop in productivity, a partial recovery, and now we're just around 8% lower than pre-pandemic in 2024. So if we move on, and you can keep going. Thank you very much. So I thought I'd talk a little bit more in detail about the components. I've already mentioned that we have inputs with labour, procurement of goods and services, and capital consumption. I just want to make the point again that the labour side, we tend to have direct measures, so we can get this information from health trusts and primary care settings about the number of people employed. So we don't need to think about wage changes or anything in that. We're actually measuring the number of people employed. That's a different story for our other inputs, where we will have that indirectly measured, we're through expenditure usually, so how much has been spent, and then we will use appropriate price deflators to try and take out the price effect to bring us back to a volume concept. If we move on now to outputs, I think this is quite important because Paul's going to follow me and give a presentation on NHS productivity, and I think it's important for us to draw the distinction here about the outputs we're measuring. When we're measuring productivity, it covers a lot of different settings. So we have got hospital settings, but we've also got community prescribing, we've got primary care, so GP, other types of primary care services. We have that non-NHS provision, so that's when the independent sector steps in, and particularly relevant in the COVID pandemic was the testing, trace and vaccinations outputs that we needed to do then. So it's a full range of stuff that goes into healthcare. If we move on, please. Yes, so let's talk about some quality adjustments. So the quality adjustment, as I said, is to get over this point about we don't have a price, so we need a measure of quality. We give a very high weight to the outcome that's been achieved. So in healthcare, this is QALYs, life expectancy. That's all about the outcome that's been achieved. But we have a smaller weight for other elements. So how the outcome has been achieved, how satisfied patients are with the service they've received, that fits into it. And similarly about when, so the timeliness, so waiting times and cancellation rates feeds into that as well. We work a lot with NHS productivity estimates and University of York for those patient outcomes for elective and non-elective care. And if we move on. Great. I will only briefly mention the Public Service Productivity Review in the interest of time, but for the last 2 years, I've worked on the Public Service Review. So this was commissioned by the former Chancellor Jeremy Hunt, who recognised that he wanted to improve productivity in public services and has a special interest in health, as he was a former Secretary of State for Health. So, and recognised that you need to make sure you need to have the right measures before you can start making policy decisions. So we conducted a review. We've already got this good foundation, as I said, following the Atkinson review. So lots of work, good work had already been done. And I think it's important to call out that public services contribute to about 20% of the UK economy. So, you know, not trivial if you want to look for ways to boost productivity. And as wider context, you're probably all familiar with the fact that wider productivity in UK, we have a productivity puzzle, and productivity growth has stagnated since the financial crisis in 2008. So we're in a backdrop of very weak productivity across the board. So just to call out on the next slide some of the highlights from the deliverables. I'll just call out a couple of these that are more relevant to health. Obviously, we improved the types of work that we were doing, but I think a really important aspect was for healthcare was that we introduced healthcare as a separate element to our quarterly publication. So before we just did that at UK total all services, but given the importance of health, we separated that out, and that also then led to lots of work with us working with NHS England and Department for Health and Social Care colleagues on comparing our estimates and making sure we were using comparable data where available. And also we had some new pilot surveys. So I'm not going to cover them today, but we looked at the management practices in health trusts, and also the time use of people working in healthcare. So how do people spend their time, to identify, you know, whether people were allocating time to not their primary role. And we built on that by sharing international best practice. So yes, I will skip on in the interest of time to talk about yes, this is, we've pretty much seen this chart, so we can move on actually, because we've called that out in healthcare. So let's move on. And then this is a really interesting improvement we made. So I mentioned that through the productivity review, we made improvements to healthcare. So I just wanted to call out one as an example of good practice. So when we look at outputs, we want, in general, I mentioned there's no price, but in the absence of price, what we tend to use is cost as a proxy. So when we want to weight all these things together, so you want to weight things together, we use cost weight. Now, that isn't always a good thing. It's the best we have available in a lot of cases, but what it means is very expensive procedures have a much higher weight in your productivity model, which isn't always the best case. So we've started to explore equivalization of weights. And in this particular case we have here would be for knee surgery. So some providers were able to do that as a day case, and some had an overnight stay. And in the traditional cost weight approach, the overnight stay would obviously have a higher weight, but that may not be the best place to provide that. So it's sort of a perverse productivity result. So what we did was we equivalized those weights. So that means that there's an incentive to shift to the right setting for the procedure. Now, we did also take into account that there may be reasons why patients would be admitted overnight, so that has been included there. Similarly, we did this for ambulance services. So instead of picking up people, taking them back to hospital, there's a lot that can be done at the scene. See, hear, treat. So that was also equivalized. It's something that we want to do more of as well. Particularly, one of the things we want to work on next is A&E services. So equivalizing, that's very expensive, but some of that could be provided in a primary care setting. So equivalising those weights may alter incentives. And then just to finally end on like our big challenge, which is around preventative services. So if we move on, skip on 2 slides. Yeah. So this is a big thing. It's one of the big key deliverables for the NHS as well, is around thinking about preventative services. Now, I've already just mentioned costs when we were talking about equivalisation of costs. So preventative services by their nature are often low cost. So a smoking cessation programme might not cost much at all. And the idea is you're preventing a very high cost treatment in the future. But we don't have any way of incorporating that. So the preventative service is only included as its current cost. So it has a small weight. So that's a problem. It is very hard. So the approach we took during the review was twofold. So we took a couple of different ideas. So if we move on to the next page. Yes, so effectively it's like, okay, well, is there an alternative to this cost weight that we could use for preventative? Is there a way potentially of having a probabilistic related cost weight? So what's the probability of this thing happening in the future, the cost of that being avoided, and could we factor that in? It is challenging though, because it becomes a question of attribution. So how much is that as a result of the intervention, the preventative service, versus stuff that the patient might be doing themselves, for example, joining a gym or eating more healthily. And so what we did during the review, if we move on to the next slide, we commissioned an alternative approach, which Martin Wheel has developed using diabetes as a case study. So we started with a case study to think about, okay, well, what are the quality adjusted life years gained from that in the future? So rather than taking on that probabilistic approach of what was cost avoided, there's an ESCO research paper which is linked in the slides that people can read to have a look at it. But we're still at the stage of thinking this was a really good case study, but how would we implement that into our estimates? So I think that's everything from me. I'm going to stop sharing because that was I didn't really add any value in that sharing screen thing. But in these slides, we've also got some further information that you can find out more on. And yeah, and looking forward to your questions when we get to the Q&A later. Thank you very much.
Thanks very much, Catherine. So just to remind people that we'll actually move straight on to the next speaker, which is Paul Healy from NHS England. And that just please, if you've got any comments, queries, put them in the chat, and then we'll pick them up in the Q&A, issues that you think about taking forward, not just specific queries on the presentation. So please put comments in the chat so that we can pick them up at the end. But now we want to move on to our second speaker, which is Paul Healy from NHS England. So over to you, Paul.
Excellent, thank you. So yes, Paul Healy, I'm Deputy Director for Productivity at NHS England. And just to follow on from what Catherine was saying, because I think there's quite a lot of good alignment between the work that we are doing on NHS productivity and the work that the ONS has done over many years. And just to kind of set as the context for us right now, the 10-year health plan, which was published by NHS England and Department in July this year, sets a very clear expectation on productivity for the coming period and covers the spending review period that we have agreed with government, which is that for the next 3 years, the NHS has a target to deliver 2% year-on-year productivity gains. And that's expected as a minimum then to return us to the pre-pandemic levels of productivity. So where Catherine was highlighting that productivity gap to pre-pandemic levels, so 1920, by delivering 2% a year gain, that's expected to close that gap by the end of the spending review period. And obviously it's a balancing item in the spending review settlement itself. And so really important for us to be able to deliver that target and in order to make sure the financial balance within the settlement works. And so that's been set out in the 10-year health plan. NHS England has also set that out in its medium-term planning framework document, which was published a few weeks ago, which sets off the planning process for the NHS, which will be over the next coming months, will be setting plans for the next 3 years based on an expectation of delivering 2% a year productivity gains. And so if you just go to the next slide, what's important for us to be able to do that is not only do we need to be able to understand what's driving productivity in the system, but we need to be able to measure it in a way that can both support accountability and understanding of delivery of the target, but also can support systems to improve and understand where there may be variations. So that's why, in addition to the estimate that the ONS produce, we also produce a monthly NHS Trust productivity estimate. So we focus on the inputs and outputs of NHS Trusts, so 205 individual secondary care providers. And we use a methodology that's broadly aligned to the Office for National Statistics. Obviously, the scope is different because our focus on trusts, but also we have some slight methodological differences that are based on the data that we're able to access and the work that we've been doing with trusts, which I'll talk through in just a moment. We're also able to estimate those trusts because we estimate those at the trust level. So the inputs and outputs for the trusts individually, we can then aggregate that to systems, so part of the broader systems that they're part of, the regions, 7 regions that we have in the NHS in England, and also for the NHS nationally, but obviously focused just on secondary care sector. We produce our estimate with a 3-month lag, so slightly similar to the ONS quarterly measure. Our latest estimate is at month 4 year to date financially, so it's April to July 2025 compared to April to July 2024. And we're just finalising our numbers for month 5. And our estimates are focused, as I mentioned, on a year to date basis. So this is how we do financial planning in the NHS. So we are constantly, as the year develops, increasing the scope of our estimate. So at month 3, we're comparing 3 months to the previous 3 months, but by month 12, we're comparing the full 12 months with the full financial year. Obviously, we can break those down in terms of different parts of the year, but there's quite important reasons why it's important for us to build the picture as the year goes on, linked to how some of the data is reported. But also the target that we're focusing on as well in terms of accountability is a target for the annual position. So by the end of the year, it's the delivery overall, but obviously recognizing that in-year performance will help guide actions that need to be taken to address any underperformance. We are shortly due to publish that estimate as an official statistic in development. We will be publishing that probably in the new year. We're still trying to finalise the exact time it will be published, but nonetheless, we produce the estimate as management information, and we do summarily publish it, particularly to NHS England board, but also through the work that's being done currently in the NHS oversight framework. So linked to the NHS league tables that were published in September. There are estimates that are included in that for acute hospitals, which through that we publish the estimates. So the estimates do get published as part of that, but they'll be on an official statistic basis. So with the requirements of the UK Statistical Authority shortly to, and I'll be lead analyst on that as well. So we'll just go to the next slide. What I'll do is I'll just talk through briefly the methodology, but a lot of it, as I mentioned, is aligned to what Catherine kind of talked through in terms of how the ONS measure productivity. Similarly, say it's inputs and outputs. On the input side, we use the monthly expenditure data that gets reported to NHS England by trusts. So this is the data that is the basis for audited accounts and will be scrutinised regularly as part of NHS financial oversight. The resource use that we estimate is based on the operating expenditure that's reported in those returns. And some adjustments that we make to those is we deflate for headline pay awards. So we are taking total pay spending from those accounts. And so we deflate directly for specific pay awards, so headline pay awards, mostly because we're not looking to measure that. We know that's going to have an impact on the total pay spend. There are some specific pay factors we have to measure out as well. So for example, where you have the employer's national insurance contribution increase this year, or you have specific changes to like pension contributions. So again, we're not looking to measure that as part of NHS performance. And so we will deflate those directly, as well as an economic-wide measure of inflation, drawing on various external sources of that. There are some other adjustments that we make for some specific spending items. So there are some things that can create distortions, particularly on a year-to-year basis. So things like redundancy payments, we will adjust out. And there are also some payments that aren't on the operating expenditure ledger, which we bring in around, for example, public dividend capital, which is in a sense a way of financing the kind of revenue support. So we bring that in order to kind of put it on the same basis as other sources of funding on the operating expenditure. And then there are some elements, and this is areas that we've been trying to develop in engagement with trusts, is where we look to remove some spending that may not be adding value in quotations, because essentially things which are spending which don't impact on the activity that we're measuring. So a good example of that is private patients. So we aren't capturing private patient activity. And so we have included an adjustment to remove what we use as a proxy for private patient spend in order to ensure that we're not capturing the inputs, but not capturing the outputs. There's also a specific challenge around high cost medicines, which I'll talk to in a second, because it's one of our challenges. And so just go to the next slide then, the challenges of our input calculation. So we have a lot of challenges in measuring productivity. And so just to be clear about all of the challenges, or a lot of challenges that we kind of face. On the input side, we have accounting distortions because we're using operating expenditure. There are lots of things that can come from that are due to accounting, accruals, and various other corrections. Trusts are not able to correct their reporting on accounts in previous months, so you can see some corrections as the year goes on. Because we're doing the because we're focusing mostly on the year-to-date basis, those do tend to correct themselves because the year-to-date picture will have the kind of full impact of that correction. And also things like where pay awards come in different parts of the year. Again, on a year-to-date basis, you won't necessarily have any issues distorting that as the year develops. But if you're just looking at a specific part of the year and comparing it to the previous periods, you may end up picking up some of those accounting factors as well. We have had a lot of feedback from trusts around what they kind of deem as investment spending, so where things are being spent for an investment and not necessarily delivering activity in the short term. That can have a impact on their productivity estimates. By and large, over a long period of time, that won't be an issue, but certainly when we're looking at this from a perspective of performance, they do point out many of those bits that have an impact. Some of the things that are highlighted us in that kind of space are trusts. There's some trusts that spend a significant amount of money on research and development, or are delivering services or specific laboratory services that are being funded for research and development purposes. That won't necessarily be picked up in our activity data. So if they have significant increases in their inputs, that can sometimes distort their productivity. Education and training is another one where they might have a significant number of trainee places where they're delivering training for resident doctors or other clinical placements. And again, that might not then show up in terms of their activity. A lot of those things will have a longer term impact on productivity and outputs, but it's more about kind of managing the short term impacts and making sure we're not, through the measure, having any perverse incentives on other aspects of policy. I mentioned about high-cost drugs. So we do have a specific challenge around the treatment of high-cost drugs and devices. So there are a set of medicines and devices that are specifically very high costs, and so therefore aren't funded on a regular basis. And so what happens is they are funded usually on a pass-through basis. They are paid directly through the integrated care boards to fund. That means they're not in the costing data that's used, and Catherine mentioned around weighting and the value of outputs. And so therefore it can be difficult to understand how we treat the high cost drug spend and devices. We had an approach which used the spend as a proxy for the output, but that was having quite significant distortions because of the way it's reported. And so what we do now is we remove it instead on the input, so we don't have that input going in, but equally it's not counted in the weightings from the activity going out. It's not an ideal situation. We still want to work on that in terms of understanding the best way to kind of capture that spend and also the value that's adding. But for now, we're kind of managing the distortion from year to year that might happen, and particularly trust to trust. There's also issues around purchasing where services are purchased by trusts by other trusts, so they sometimes subcontract, and sometimes the activity is captured against the activity is captured against the trust that they are subcontracting from. That can have a distorting effect. So we're just managing and looking through how we deal with some of those things. And then equally, there's a broader challenge around where spending is being done for non-patient services. So a good example up in the Northeast is there's a trust that runs the NHS Fleet Solutions, which is a lease car scheme, and it has a significant spend for that trust. But obviously, we're not capturing, car leases and stuff like that in our activity. So if that changes significantly from year to year, it can have an impact on their productivity. Just go to the next slide, please. And then on outputs, so broadly similar to kind of what Catherine was talking about in terms of how we capture it using the activity data that's reported. That activity data is reported monthly to NHS England, and that's the basis for measuring productivity, performance, like things like waiting times. It does get regularly restated by trusts in year, and that creates a challenge in terms of, an estimate at a particular point in the year might change as the year develops. So even if we look at month 3 year to date, as we get through the year, our estimate of month 3 year to date will change because trust will report activity in those months that they didn't report at the time. So we have to manage a lot of that restating to be able to have a consistent measure and understanding of what's happening in the system. There are some adjustments that we make to activity, some of which Catherine mentioned in terms of the ONS work that the ONS does. But so we do some data estimation for clear and obvious errors. So where we see errors and gaps, things like null figures or data that seems to be duplicates, we will make some changes for the purpose of the productivity on directly with the data that we have. That can be corrected in those future months, and obviously then that will replace what we've done as estimations. Catherine mentioned the equivalization, which we call equalization here. So we use cost weights to value the activity, but also we do some equivalization to reflect activity that has the same outcome. And we do some calendar and working day adjustments to reflect kind of planned and unplanned services. So when we're comparing 2 periods to another, we're kind of reflecting different activity to another, reflecting where those are 7-day and those are often shorter. So we just go to the next slide. We'll see then the challenges with our output. So the things we have to deal with, data quality is an issue. We do have good granularity in acute sector in terms of data, both for cost and activity. But in non-acutes, it's much more volatile and much more challenging. We have some issues, and particularly it comes up when we are obviously looking at trust level, where we've got big gaps in data that we have to try and address that can sometimes be due to specific incidents. So there was a cyber attack, for example, that impacted on mental health activity data that completely wiped out large chunks of activity reporting. And there's been things like implementation of patient records that have had an impact on that. As I mentioned, the point about restating activity creates just a more presentational challenge and, being clear about what the measure is and how it might change through the year. We don't measure quality in our outputs at the moment, and so that is a challenge. Certainly we have looked at what the ONS do. It's sometimes challenging in terms of looking at it from a trust perspective in terms of how we'll bring in quality, but also wider patient outcomes as well. And that does have a challenge around measuring left shift, similar to the prevention point that Catherine was making, actually, where trusts where you may be reducing activity in hospitals and delivering more in the community or out in primary care. That can actually have a productivity, it can make productivity go down for trusts, but actually is overall improving outcomes for patients and for the public. We've also had a very specific issue related to same-day emergency care. So this is about reporting in acute services where same-day emergency care had been reported into the acute data set and has been moved their reporting to an emergency care data set, which essentially means that a lot of the activity we've been capturing has just dropped off because it's been moved to another data set. We have managed that using a different approach to measuring pathways. So we are, able to manage the impact of that, so we don't have that drop off, but it's just stuff like that can have an impact in terms of what you can capture. Just go to the next slide then. Similar to what Catherine was talking about, I kind of picked out a specific example as well in terms of some of the things that we do, and this is looking at that non-acute challenge that we have in terms of data quality and granularity. So within our measure for mental health trusts, one of the things which we want to capture on the activity side is mental health inpatient services. So these are for patients that are admitted into hospitals due to severe mental health problems. What we do in our methodology is we count the mental health inpatient activity. So we get data reported to us, and the data we get reported to us we have on spell basis, so they're covering the whole spell for the inpatient stay, but also on a bed day basis, so how many days the patient is in bed for. Now, if we captured spells, if we counted it based on capturing spells, then essentially what we'd be showing is a productivity improvement if length of stay is reduced, because essentially the quicker the patients could be discharged, you would basically pick up a higher activity count. But if we counted it on bed days, we're probably more likely to capture that care of clinical value that's provided on an ongoing basis. So it wouldn't have as much of a larger impact if people are staying longer. So for example, for secure beds, so patients in secure facilities, we value the activity using bed days. So what we're doing there is recognizing that those patients have diverse needs, and the situation where actually those patients can be in in their care for months, sometimes years as well. And so we use bed days to be able to measure that and recognise those challenges. But if we go to the next slide, what we do for non-secure beds to try and kind of think about this from both perspective of using bed days and spells. Just go to the next slide, please. What we do is for non-secure is we value the activity using spells. So we use the kind of spells data to the value, but we discount value that's excess, that basically the excess bed days. So we calculate a set of trim points. So for each spell, based on the average across the trust sector, we identify the kind of the 75th percentile of length of stays for each area. And then we count the kind of ward stay up to that length of stay cut-off point and count that as a spell and count on the basis of spells. But then for activity over that length of stay, we use bed days, but discounted bed days weight. So half of the value of the activity, which means that essentially we're not capturing each bed day in terms of, an additional activity at the full weight. We're discounting it. So we're kind of balancing both the want to be able to reflect spells in order to, encourage shorter length of stays, but still having some discounting measure for those excess bed days in line with kind of the trust performance at the 75th percentile. So we think that values length of stay in a way that we want to measure, and also discounts the longer ones. It does also capture productivity in terms of discharging patients as soon as clinically reasonable, which is more appropriate for non-secure beds rather than compared to secure beds. But it may potentially overvalue short stays because we're given a ward stay spell to them at up to the 75th percentile. So it has its kind of balance either ways. And then finally, I just want to reflect then overall in terms of like how we measure productivity and some of the challenges we have. So just go to the next slide. I think the key bit for us is that obviously we need to take judgment in terms of managing data quality. In terms different from the ONS, we are putting out these numbers on a trust level, so they have to make sense to those trusts, and we get obviously a lot of feedback engagement with trusts on that. We want to utilize the granular data that some trusts have, particularly in the non-acute sector, but we have a limitation in then that being consistent and reliable across all sectors and all trusts. And so we do have to kind of manage the balance between using the good data that some trusts have been developing and having that across all trusts. There is also a balance between publishing a simple measure, something that's simple for accountability purposes and simple for people to understand where the NHS's performance is, and also wanting to make it relevant from a trust perspective, but also for those trusts to be able to use that to support improvement with frontline clinicians, for example, who where the simplicity would often get lost on them in terms of it won't make sense to what they see in their daily lives. And I think as well, we're wary of the danger of focusing too solely on a measure of productivity, particularly one that's comparing one year to the next. And actually, we want to put a lot of context around those estimates. I think for purposes of improvement, so supporting trust to make improvement, it's important that we kind of bring in a multiple set of kind of metrics and understanding of measures, of which the productivity measure can be part of. So we just go to the next slide quickly, just to show some of the stuff we do as part of that. So this is a snapshot of our model health system. This is from a trust. I've blurred up numbers because it's the trust level data, but essentially this is where trusts are able to access. We have a productivity and efficiency dashboard where trusts are able to look at the top, you can see the productivity growth measure that we have, as well as other measures that are similar to that, linked to it, cost per wow, plus weighted activity unit. And then there are specific measures linked to clinical productivity, so theatre utilisation, average length of stay, and then workforce productivity, how many admissions per clinical WTE, how elective trusts are able to look at that for their organisation. They're able to click into these charts, compare themselves to other trusts, look at the median, look at how it's changed over a time series. Just go to the next slide as well. That's on workforce and clinical productivity. Then there's also some workforce drivers, things like sickness absence and temporary staffing levels, estates and facilities costs, and then some quality measures as well. So through that, we're hoping to give trusts as much of a wider picture so it supports their improvement and puts the stat that we have in context with and those other things that they need to look at as well. And so that's my summary.
Great. Thanks very much, Paul. That's really fascinating and some challenges, but also tremendous amount of improvement and moving forward. So We now move on to our final speaker, Dr. Saad Ahmed Shah, who's going to look specifically at issues around the backlog and developed during the pandemic and approaches to deal with that, which obviously has come up in the presentation so far. So over to you, Amar.
Thank you. Can we move to the next, or do I have control over the slides? I don't, right? No. Okay. So what I'll do is, because I have animation, can you just, yeah, click through and so that the whole slide comes up, and then okay. And there's also one more. Can you click one time more? Yeah. Awesome. Thanks. Sorry, you have to go back. Apologies. Okay. Right. So as I begin my presentation, so I have two key points to make, two big picture points before I get to the meat of the presentation. So the first point is, which people who work in this field, they would have heard this quite very often. So all models are wrong, but some are useful. And this comes from one of the most influential statisticians in a paper that he wrote in 1976. And I'll just quickly read and I'll tell you what the point I want to convey is. That for statisticians, for example, they know that in nature, there never was a normal distribution. There never was a straight line. Yet with normal and linear assumptions, which we know they are false, you can derive results which match to a useful approximation, those found in the real world. So when we talk of a model, or if anybody presents a model, whether anybody presenting a model, I think the key question is not whether that model is accurate or not. The key point is whether that model is useful or not. So if you move to the next slide, sorry, keep moving to the next slide. Yeah, just stay here. Okay, so the second point I want to make is that it doesn't matter whatever metric you use, every metric will have limitations, but collectively, those combination of the metrics, whatever they are measuring, collectively they tell a story. And this is, I actually had a clip, so you can go later to the slide and then there's a reference to it. So this is a movie which some of you may have watched called Passengers, where they are doing this intergalactic journey, a 120-year journey, and they have over 5,000 passengers, and the system malfunctions, so the whole ship malfunctions, and one person wakes up, and then he wakes up this girl, and then this captain wakes up. So it's only 3 people waking up, and they still have like a few decades of travel to go. And then what's happening is the ship is functioning well, but every now and then there is some malfunction, some problem. And then at some point they want to diagnose what's happening. And then they go to this control room where they try to look at the previous data to figure out what's happening. In this specific scene, this person asks, how bad can this get? And then this captain, he basically asks the computer to give me risk analysis based on this data. So past data to make projections for the future. And then they find out that basically it says a mission critical failure is imminent. So they project that there will be these sequence of failures, and they are basically on a sinking ship. So the point I want to convey here is, when we look at various measures such as the number of patients that are seen within 18 weeks, the number of patients that are waiting for over a year, all those metrics will have their own caveats and they will have their own limitations. But when you take these and a combination of these metrics and you plot it over time, they're telling you a story about your overall healthcare system. Okay, so now if you move to the next slide, yeah, and can you press once more so that it shows the reference? So everything I talk about, so we have undertaken a sequence of studies, and they are all publicly available. These are published papers. So if you search my name, or if you search on LinkedIn as well, you will find lots of material around it, and you can go dive deeper into this. But I think this body of work that I'm talking about, it really begins in the early days of the pandemic, where for very obvious reasons, those finite resources were diverted to address and respond to the COVID-19 emergency. But then a concern back then was when we had this, the lockdown back then, the first lockdown we had, that was unprecedented measure as well at the time. So a concern then was, how would all these measures that have been taken, how would they impact the provision of healthcare for diseases and conditions other than COVID-19. So this is one of the pioneering work that we took at the time, where we looked at data from across England, Scotland, and Wales, where we tried to understand the impact of the first lockdown on hospital admissions and uh, so the immediate impact, but then which at the time looked quite long. So we also looked at the impact, how things are faring in the, like, say 7-8 months later. So the obvious, well, now it's obvious. So one of what we found was that there was a massive disruption. But what was also concerning at the time, which looked quite long, that the capacity that we had before the pandemic, that was not restored even when those restrictions were lifted. So, uh, and then as time went on, then there were these really, really important questions that needed answering, because there was this backlog that started creeping up. So if we go to the next slide, please. So some of these key questions around the backlog were like, so how big is this backlog? How much capacity increase would be needed to address this? How bad can it get? When will it peak? And then this whole concern about healthcare disruption. So there was this concern that many people might not be coming forward. So how many are missing, and what would it mean if they return? What would it mean? What would it mean for the healthcare system? So these are some really, really important questions that needed answering, and they were relevant back then, and they would be relevant in the future in other emergencies as well. So if he can go to the next slide. So the studies that we took, and please, can you press once more so that actually again as well? Yeah, thanks. So so we I think the key thing is we developed a model that could help us understand the impact of the pandemic, and then that could also help us make projections to understand how much capacity increase is needed. And it's a body of work. So I'm going to show you two papers, two key studies. One we did in NHS using data from NHS England, and then the other was NHS Scotland. So the key metric that we used is so basically, if a patient is deemed that they need to be seen by a consultant, so waiting to be seen by a consultant, and the vast majority of such patients would be those that would be referred by a GP, so by primary care. But there would be other routes as well where somebody might end up waiting. So, and the clock starts ticking as soon as somebody is referred. So if you can move to the next slide, please. Yeah, and also keep pressing so that we don't need the okay, awesome. So the two key data sets. So for NHS England, if you go to, so it's an NHS Digital, so it's the referral. It's called the referral to treatment time, RTT. And for NHS Scotland, so this is on Public Health Scotland, it's called NHS waiting time, stage of treatment. And what are these boxes that I show on the right? The amount of time that a patient needs to wait before they should be seen. It's written in the law how the maximum time they need to wait. So, and obviously there are differences, so you can't directly compare the specific measure between England and Scotland, but what we have in England is what we call so there's an 18-week period. So the standard is that the vast majority should be seen within an 18-week period, and then we have this in Scotland we have something called treatment time guarantee. So the maximum time for most patients waiting should be 12 weeks. And these data sets, they are available like publicly available, and they adhere to the Code of Practice for Statistics, which means that there have been validity checks, etc. And we would, as a researcher, we would consider them to these are data that would have like high public value or be high quality, and we would consider them trustworthy. So if we move to the next slide. Yeah, thank you. No, sorry, go back. Yeah. So because one of the key thing in the study that we have done is actually the model. So I'm not planning to go through the mathematics, but this is just to give you a bit of intuition, because this is really so central to the stuff that we have done. So the way to think of this, the intuition is if the number of people that are waiting at any given point in time would depend on the demand that is generated and then the patients that are treated. So if you think of this like a stocks and flow model, so you have the box number of people waiting, and then if it's monthly time series, then the monthly demand that is would add to the people waiting, but the monthly treated would make the people leave that the number of people waiting. And obviously the monthly demand could also be impacted by additional demands that might come because of, so for example, if there was healthcare disruption, so the missing people. But the method that we use was what we call this vector autoregression with exogenous variables. So if you go to the next slide, and if you can you press a bit more so that it just loads? Yeah. Okay. So this is just the intuition about this was these. So I just have 2 or 3 slides which actually goes through how did we end up from first principles to the equation that I showed in the previous slide. And it's a case of, if you imagine you go to, you are setting up a new hospital or new planet. So a simple model would be the number of people waiting at any given point in time would be the demand that is generated. So that would add to the people waiting and minus treated, then you would subtract it. So that would be this y sub w is equal to x sub d minus x sub t. However, we are going to monitor month by month. So that's why we have this index term. So that's why what you see at the lower end is this, there is this y w of n, well, so they're a function of the time series. So this is like discrete time analysis. So if you go to the next slide, please. Yeah, keep on going. Okay, great. So, and then the other thing is that obviously in real world, you don't start from zero. So at any given point in time, there would already be people waiting. So the number of people waiting in a given month not only depends on the demand and those who are treated in that month, but also the number of people that were already waiting. That's why we have this additional term. So y sub w of n, y of n minus 1. And then the thing is, at the moment, the demand and the treated time series, if we just have like it's a plus and a minus, so the coefficients of these are a +1 and a -1. That would be if we had a very simple system. But the reality is that real world data, it's very noisy, it's complex. There might be patients might be removed without being treated for other reasons, etc. So that's why what we do is, and also the other thing is the number of people waiting in a given month might not only depend on the previous month, but they may depend on several previous months. So to factor all these in, we are going to add additional coefficients for the demand, the treatment, and then we'll increase the order of these, the previous month. So if you go to the next slide. Yeah. I'm going. So here, all I'm doing, which you can go back and read the papers, is how we go from those first principles to this complete equation. And then the key thing here is, unlike many other approaches when you are modeling, is we don't decide on what the values of these coefficients are. We use all the historical data and then use optimization to find out what would be the best coefficient values that represent this whole system. And this is what's the essence of what generally we do in machine learning. So if you go to the next slide, please. Yeah, so this was the first study where we developed this model, and then we started looking into how much capacity increase would be needed. So this was NHS England, and then we did these different scenario projections. So if you don't increase the capacity, what it means for the backlog, if you increase it by a certain percentage, 10%, 15%, and so on. And then we also had to make various assumptions about the number of missing people, how many may likely end up. And the data that we looked was from several years before the pandemic. And what you see in the graph is actually the number of patients waiting. And what you should notice is that even several years before the pandemic, the waiting list was actually increasing. There was always a gradual increase. And what happened during the pandemic was that it just accelerated those number of people waiting. So So it's a case of we already had a challenge. We already had the demand was exceeding the capacity. So we entered into we walked into the pandemic where we had an existing problem, and then pandemic just exacerbated that problem. So if we move to the next slide, yeah, and then as I said, there's nuance to like the modeling approach we use. So there's whole debate around. So you can have a very mechanistic approach where you are modeling a system, and but the one we used is a purely data-driven approach where take you take all these historical data and you try to find the best parameters that fit that data. So this is a more data-driven approach or more machine learning approach. But there is an extended video that explains this and some references that you can deep dive into. So if you can move to the next slide. And then building on this, when we had this established model and we had an approach, then we got a bit well, as time went on. So we did a more detailed study looking at Scotland, where so one of the objective was assessing the impact of the pandemic on this elective care backlog, but we also wanted to estimate and also the capacity increase that would be needed to address the backlog. But because by then the government had made announcements of how like they had various targets, and so we also then looked at how much recovery has happened and how things are going. So and this is also a study that we have published. So if you go to the next slide, please. Yeah, so again, very similar. If you look, I mean, visually, the waiting list, what you see is even several years before pandemic, very similar story, gradual increase. Then there's a massive increase during the pandemic, and then we have done some projections, like how much capacity increase would be needed. And one of our key findings were that there needs to be a substantial increase, and obviously we have quantified that, and that needs to be sustained for several years, and it will take several years of sustained capacity increase before we are able to see a substantive decline in these backlogs. If you go to the next slide, please. And then, as I said, we also got an opportunity to assess the recovery effort and whatever. I mean, there have been revisions, obviously, as well, but whatever plans were announced, I think the bottom line is that what actually was achieved until the data that we had and we looked into this, and what was announced, there was a complete mismatch. So between the progress in recovery. So if we go to the next slide, please. Now the other thing is in these kind of studies, there are several places where we make assumptions. So in the interest of transparency and for anyone to look further into this, so all the data that we used is all publicly available. All the code that we use, that's publicly available, and that gives an opportunity for people to change the assumptions and the scenarios, and then they can run and find out how things are going and how much capacity increase would be needed, etc. And also, I didn't show this here, but the studies that we did, we obviously looked at overall, we looked at different specialties, we looked at different regions, etc. So they were very, very detailed. So there's a very inflated appendix, supplementary material with these papers that you can go and have a look. Can we go to the next slide, please? And yeah, we got an opportunity to talk about this in media. So the study that we did for the one from Scotland, that was covered in some of the front pages of a few national newspapers. We got to speak to BBC and other media as well. It was also referenced in the House of Commons as well. But I think the bottom line was that whatever targets the government announce, I think there needs to be a really, really strong collaboration between the government and the health boards or the trust to make sure that whatever targets are set that are realistic, and also it needs to be made sure that the adequate resources and funding is made available so that we can make progress in recovery. I think that's all from me. So I'll happy to take on questions once we have the Q&A session. Thank you.
Right, thanks very much. That's also very, very challenging in another way. I mean, obviously they've all been three very challenging and very interesting presentations. So we're now on to the Q&A. So whether the speakers could just come on get their video active, that's really great, and we can have a so if we move on the slide, because I think we've just to the end of presentations, questions and answers. Then the next one I think just says what. Can we just do the final? Okay, right. So just to say, obviously everything's going to be posted and we can offer comments afterwards, but we haven't had anyone putting anything in the chat as far as I can see, because but maybe there's absolutely stunned by the amount covered here. There's obviously an awful lot of challenges, but I would actually say that from when I first started, and obviously white-haired here a bit before some of you, it's amazing how far things have moved on, in that, it just used to be really very simplistic, counting numbers of patients through without any kind of thought about capacity or quality adjustment or anything at all. So, we've moved on in great leaps and bounds, but obviously there was a lot of challenges. But yeah, I mean, Amar, you want to offer a comment or a query for the, yeah.
I'll wait. I have a question from Catherine, but I'll wait if somebody else.
No, go ahead.
Okay. Yeah. So I was curious, Catherine, looking at, you said that we have this productivity paradox since the financial crisis. We haven't managed to increase productivity, but and then the graph that you showed, actually the productivity was the public productivity going up until until the pandemic, which was quite interesting. So just wanted to understand what's going on there. And then the other thing is the work I showed, what was really obvious to me when we look at just the total number of people waiting, I think one of our conclusion was that the problem started many years before the pandemic. But I think it's not during the pandemic that but the pandemic just made it worse. But I think the graph you showed, it's hard. I'm trying to, maybe I misunderstood. How do I reconcile with that paradox point and also the stuff that I did? Thanks.
Yeah, lovely. Thanks. So the productivity puzzle is a private sector phenomenon, a whole economy problem. We thought it was sort of more limited to the UK, but actually more research is showing that it was a global phenomenon as well. That productivity before the financial crisis in the UK was around 2% a year, and often then people use 2% a year as like a bit of a baseline as a target, like, oh, we've got to be 2% a year because of that was what it was before the financial crisis, and then it really flattened off. I think actually. As we're here at the RSS, I think it was actually the RSS stat of the decade that productivity growth in the 2010s was just 0.1% a year. So when you compare that then to healthcare productivity, so healthcare productivity has sort of punched above its weight in terms of like it's outstripped in those early years and also it's outperformed a lot of other public services. That isn't necessarily it's still not like, huge numbers. We're still talking at less than 1% a year on average, but there is definite growth there, and I think there's twofold potentials for where that's coming from, and you do see in health, but definitely if you look at something like education, you see an increase in productivity from the 2010s. So when there was a the sort of austerity periods actually put a restriction on inputs. So it wasn't a productivity story in that we were producing more and doing a lot more, but you were actually reducing the input. So it's a slightly different story in the periods from the 2010s onwards, which is very in contrast to sort of the wider private economy of what was going on at the time.
So it's a complex picture. So if you're kind of saying the productivity is going up because you're doing more for less, but actually if you're putting less in, then you can see that some measures then will...
And there's a longer term question there, because you really want to look at productivity over long term. And if you might have short term improvements, but if, for example, you're not investing in capital, so I mentioned education already, but this also would apply to sort of hospitals or whatever. If you're not investing in buildings, for example, it may be that then things start deteriorating over time, and it's only for so long that you can hang on having that, putting less in without having the investment. And then that's a general sort of story across the whole productivity puzzle is the link between productivity and investment. And it feels like it could be lack of investment. It has very close links to stagnations in productivity. So you might be able to make short-term gains for holding back spending, but actually investment, it could be the way to sort of push forward, push future. But that's sort of I haven't got a policy hat on there. That's just sort of my observation from what the data showed in the past.
So you're talking investment in capital, but also resources, capacity. I mean, capacity covers lots of different things as well, which is clearly what Anna's trying to say, that some capacity increases. You want to be efficient, but actually at some point you need to say you've got enough capacity to deal with things. What it does sort of seem to bring out is needs to be really clear about what you're actually measuring when you're actually presenting a picture or a measure. You actually need to say, this is showing this aspect of it. It's not like one number, is it? Paul?
Well, I was just going to say, I think that measurement point is also important to understand, like how measurements could also be impacted in some of those periods as well, because that period, particularly 2010s, is also the period where you've got the most granular data, and it's being used in the NHS specifically, looking at the costing data and looking at granularity, particularly how the tariff was set. So that may also drive some of the activity in the coding and reporting and the delivery in those spaces. But equally with the pandemic, a lot of the things that you might have wanted to measure on the output side, we didn't necessarily have the measurements. I've got to adapt quite quickly to have completely shift and change in services. And so again, it can sometimes the measurement could be having an impact on why it's such a drop off, and also why you have increases as well.
And I think there's this sort of with the changing environment in terms of the data that's available. I mean, some of it's improved and some of it hasn't, so you can possibly do more. And I was also thinking about changing, very interested in some of these additional measures that Catherine was talking about, which is really, really important in terms of she was talking the final bit of the equalization, and also the preventive services, because it's not just the hospital, and actually bringing those in, so you're actually getting a broader picture of the value of what's coming out at the other end. This is sort of more with a public health hat on here, but that actually raises that, how are you going to actually present that? Because basically, if you've changed what you're measuring in terms of productivity, and you're able to actually be more sort of effective or broad in the picture that you've got, then actually you're going to get a different number. So how do you present that? Because productivity will change because you're changing the way you're measuring it, even if the way you've changed is improvement.
I can come in just to say, so this happens a lot. Obviously, we've made a lot of improvements, and some of them come in at certain points in time. So we are quite transparent in our methods about having breaks in the series where we know that the sort of data is only available. For example, this year we introduced a measure of tax productivity, but we've only got that from 2018 onwards. So there's various things like that we include. But where we can, we try and revise the time series too. So if you're introducing a new service that you haven't measured before, or then you try and take it back as far as possible to give you sort of a more consistent time series, and you don't want to just sort of have jumps. So when you introduce things, I suppose the other thing is, as well as making sure that there's you've got all the inputs and the outputs for the same sort of service, because you don't want to mismatch where you've measured things on the input side but you're missing things on the output side. So that's where we plug the gaps with the inputs equals outputs approach, but knowing that that's sort of like an inferior measure to a full quality adjusted output.
Paul, and also encouraging anybody else, this is just kind of like top table type discussions. Feel free to chip in if you've got other comments or queries. But Paul.
Well, the other challenge, I guess, and particularly with regards to preventive services as well, is so if you're capturing health productivity, is obviously the impact that those things can have on productivity more widely. Certainly, there's been some work recently that NHS England has done looking at kind of tax data and linking that to activity to show around the impact that reducing waiting times can have on the wider economy, people getting to work, and those kind of things. And again, I mean, obviously ONS can look across quite a wide range of different services and different parts of government and the economy. But you say, if you look at healthcare productivity, there's going to be some of those outputs, particularly on the preventive side, that actually are going to impact on services beyond healthcare. I mean, one of the things that's been happening, because we've been looking at specifically around the work around things like weight loss drugs and stuff like that, where you can potentially, reduce the demand for more severe comorbidity kind of care, is understand that a lot of the benefits of that might actually be felt and seen in activity that's being done in the welfare system or in the work or other parts of the system as well, which I think is quite, important to think about.
Yeah, and I would actually say there's that series of ONS webinars looking at sort of data, and there was the one fairly recently, which was bringing health and wealth data together. That was a really, really interesting one. So if people haven't, we can put that link in the material as well, because that's saying that actually if you start to bring data together from different areas, then it's not just health. Health is affected by and affects a whole range of other things. So that's really important. So that, I think that's the sort of broader perspective on it. And I don't know whether or not there's also Alan, we think, you were looking specifically at the kind of waiting times, and it's waiting times for consultants, as to whether there are changes. Catherine was talking a bit more about the preventive services, different ways of doing things, whether there's another piece to look at that and say, well, actually, is it not just more capacity to deal with that within the hospital side, but there's actually looking at alternative ways of maybe reducing people getting on the waiting list in the first place, but by preventive services or primary care services. Is there a sort of more detailed, in-depth analysis needed there?
So there, I mean, because in healthcare, I mean, everything affects, like
Everything.
there is so if you have better primary care services, it will help at the other end. The thing is, for us, as working in a university, I think it comes to the availability of data and where we can get data. So there is a complementary work that needs to be done for primary care to understand how things are. But also, so some of the patients that are waiting for longer, we also need a more detailed study looking into what would be the impact of like waiting longer for certain diseases. Waiting longer might the adverse there might be a stronger association with adverse outcomes. So at the moment, based on the conversations I've heard and based on presenting this, we don't have a really good even like a model or a formula for prioritizing patients who are waiting for longer. I mean, it's not based on any diseases as such at the moment. And then there's also stuff that needs to happen in unscheduled care as well. In parallel, where you need to understand how that is changing, how that's evolving, because there's a knock-on impact in either direction.
And I think that what also this sort of reinforces is the value of the the relationship and the link between the different organisations. We've got ONS and NHS England, but also the academic world, in that you're identifying, I mean, Catherine and Paul, identifying issues, but actually in order to unpick those and find out, you know, what are the things that are affecting it, and how you can actually bring those effects in, you then need to work with academic colleagues who can then take the time, access the data and do the analysis, because it's not a straightforward collect the data from the hospital and just run it through the system. You identify issues that need further investigation.
Yeah, I'd agree there that we can do more as well on linking up. I mean, in ONS we work quite closely with the Economic Statistics Centre for Excellence, which is a collective of academics. We also work with University of York on healthcare for productivity, so we have some established links. But just because it's in my head, because I was there yesterday, I'm an operational researcher rather than a statistician, and I was at the OR Society's healthcare forum yesterday, and that brought together OR practitioners in healthcare with frontline health providers to show them the value of data, and we talk them through sort of similar work that there's been going on around waiting times, and they were talking about different projects, particularly that happened in the devolved governments as well, so in Wales, England. So that was a really good way of bringing those things together, and I think more sorts of things like this and like that are great ways to bring the academics and the practitioners together.
Yeah. Paul, you're on to
Yeah, I mean, and so the close work we've been doing with the University of York as well. I mean, I think the other thing to highlight is within the health kind of policy space, the Health Foundation are currently leading a productivity commission for NHS productivity. They published a report last week and are doing a call for evidence in December, and that's got in it, that report, some work they've done around looking at international comparisons for productivity, NHS versus others, but I think, and also looking back on that kind of what's happened over the last decade or so. But I think, we kind of look to try and support as much of that work as possible, because just what we're saying there about those periods before, it would be good to kind of have some good academic work that looks into the data. That there's quite a lot of data out there, but what might be driving some of those things.
Yeah. And I think that, I mean, we're sort of getting to the last few minutes, but actually that does lead into the recent letter from ONS about the changes in focus, and that maybe there's going to be less on healthcare statistics or health statistics, but in discussion with stakeholders and other people as to what could be done by different people. And so I'm hoping that statement isn't just, oh, we're going to cut back on health statistics. It's actually saying we all now need to work together and say, first of all, show how the analyses that have been done have been very helpful and useful. So what's the value from the analysis? And I think, you can clearly see from the work presented today that there's a lot of value and impact from the analyses, but also that actually, if you're going to say, well, maybe ONS doesn't do some of those because someone else is picking them up, and you can actually, by collaborative working, you can get more out of it between the different organisations and the academics, then that's a way of saying, well, it doesn't have to all be ONS, so that we don't actually lose something. We're actually using this as an opportunity to sort of collaborate and work together with all the stakeholders. So I'm hoping that this is, demonstrates how important it is to be able to exchange ideas and present and actually collaborate in these very, very important areas. So, well, the rest of the participants have been quite quiet, but I hope you found the discussion interesting. And there's a lot of material on the presentations, and including, Aman's got this sort of link to a little video and various other things. And, you could spend days actually, when I'm looking at the slides before we started, on the links and following up on that. But there is an opportunity when we post the material, particularly within the Analyst X, within Future NHS, to offer comments and discuss. So, we can take the discussion forward. And if anybody participating here is not currently hasn't got able to access Future NHS, it was originally set up by NHS England, but it's now open to others within the health stats community. So contact us and we can make sure that you get registered on that so you can participate in those online discussions to follow up from this. So I think that's now, we're sort of finished in time, but thank you very, very much to the speakers for some fascinating presentations and for the work that they've done. Apologies for some of those glitches at the start, and also thanks to Janina for stepping in to actually move the slides through, which wasn't what was intended, but I think but it really worked very well on the day. So thank you for participating, and if you've got any comments and thoughts afterwards, still feel free to contact us. So after that, I will close this and enjoy the rest of your day. Thanks, particularly Catherine, from your beginning. Yeah, thank you.